Thank you. So next I invite Dr. Rupal. She'll be talking on the non-neovascular pachychoroid spectrum, and she'll make us understand those subtle changes which happen in the pachychoroid diseases.
Good morning, everyone. Thank you, AIOS and Dr. Ramesh sir, for this opportunity for presenting in this IC today. So today I will be covering the non-neovascular pachychoroid spectrum. Pachychoroid, by definition, as we all know, pachy vessel is focal permanent dilatation of the choroidal vessel in the Haller's layer, causing attenuation of the overlying satellars and the choriocapillary layer, which with or without RP abnormalities and with or without increase of the choroidal thickness. Pachychoroid spectrum, it is a group of disorders characterized by an abnormally thick choroid with distinctive vascular alterations. While much attention has been focused on the neovascular complication, the non-neovascular entities often manifest subtly but can provide critical insights into the choroidal pathophysiology and long-term evolution of the disease. So these are the non-neovascular entities that we know of. First one is the pachychoroid pigment epitheliopathy, central serous chorioretinopathy, peripapillary pachychoroid syndrome, and the focal choroidal excavation. So I'll be dealing all of these in detail. Pachychoroid pigment epitheliopathy, it is an asymptomatic condition, or it is often seen in young individuals. It is also called as the formifruste of CSCR. The fundus features in these include a loss of fundus mosaicism and a red diffuse posterior pole appearance due to the pachychoroid feature. RP changes are often found in the macula, and sub-RP deposits can be seen. SDOCT reveals a thick choroid, small elevations of the RP representing the RP hyperplasia and sub-RP drusen-like deposits, small serous PEDs, and the outer nuclear layer thinning. Fundus autofluorescence reveals a mottled hypo and hyper-autofluorescent areas, which are seen in the areas of the RP changes. So this is an OCT image of pachychoroid pigment epitheliopathy. As you can see, there is an underlying pachychoroid vessel, overlying which you can see the RP alterations. So this is the FFA and the ICGA of the PPE. As we can see, there is hyperfluorescence seen on the FFA as well as hypersenescence seen in the ICGA due to the increase in the leakage from the dilated choroid vessels. Then a word about pachydrusens. These are drusenoid deposits which are large in size, more than 125 microns, which are seen in the context of pachychoroid vessels. These are seen as isolated, scattered, yellowish-white deposits beneath the RP layer, mostly concentrated on the posterior pole. The prevalence of pachydrusens is around 41% in PPE, 60% in CSC, 61% in PNV, and 70% in PCV. So it can be considered as a potential risk factor for disease activity in pachychoroid spectrum of diseases. So the second image shows the pachydrusens. Next, a word about central serous chorioretinopathy. It is a condition which is characterized by RP alterations along with the serous PED and SRF collection. Here, the patient presents usually with reduced vision, metamorphopsia, and micropsia. Clinically, it is seen as a serous detachment at the macular region. It can present either in the acute form or chronic form, and although typically self-limiting, recurrent episodes can be there, which can be vision-threatening. This represents the pathogenesis of CSCR. It can be due to the increased inflow and the decreased outflow. Increase in the corticosteroids and epinephrine levels leads to choroidal hyperpermeability, which leads to thickened choroid and collection of fluid under the RPE, which results in a serous PED, and a rip in this PED, which will lead to collection of fluid in the subretinal space. Then, due to the decreased outflow, the pachychoroid causes the compression of the overlying satellars and the choriocapillary layer, which leads to the retinal pigment epitheliopathy, which is a dysfunctional RP, which leads to poor absorption of the fluid from the subretinal space. The OCT characteristics of CSCR include, in the acute form, we see a serous detachment with or without a serous PED. In chronic forms, we see a shallow, broad detachment with outer retinal atrophy and cystoid macular degeneration. FAF shows areas of hyper or hypoautofluorescence related to the RP changes that are seen, and also vertical gravitational tags of RP hypopigmentation are seen. FFA in the acute form can reveal an ink blot or a smokestack leakage, and in chronic form, it will reveal multiple indistinct leaks within the granular window defects. ICGA will reveal a choroidal hyperpermeability with the dilated vessels. This is a case of CSCR. As you can see, there's a serous PED with SRF collection at the macular area. 1 month later, we can see there's a decreasing SRF. Here we did FFA ICGA and found a focal leak. And since it was an extrafoveal leak, we went on to do a focal laser in this patient, and there is a good resolution of the SRF that is seen. This is another case of CSCR. Initially, we saw drusen-like deposits, and then a month later, the patient presented with a serious detachment. And on FFA ICG, again, we found a focal leak. The patient again underwent a focal laser in this case as well. This is a patient with a chronic CSCR. As we can see, there is a outer retinal atrophy with cystoid macular degeneration and pachyvessels underlying. We can see these diffuse mottling at the macular area, hyper and hypofluorescence. Here the patient was started on eplerenone because there was not much of a visual improvement that we could have expected in this patient. However, after treatment at 3 weeks, there was some resolution that was seen in the intraretinal and the subretinal fluid as well. Next entity is a focal choroidal excavation. It is an asymptomatic condition. Sometimes the patient can present with subtle visual distortions. These are areas of localized choroidal excavation without any scleral ectasia or thinning. On imaging, we see that there is choroidal thinning with an area of excavation with an intact neurosensory retina. There are two types to this. There's a conforming type and a non-conforming type. In the conforming type, we can see that the photoreceptor layer and the RPE have approximation, and whereas in the non-conforming type, we can see a cleft in between the RPE and the photoreceptor layer. We call this as the hyporeflective cleft. The conforming type is mainly due to the retinal elasticity. So initially, we can see the conforming type, which can later progress to a non-conforming type, which would lead to a detachment between the RPE and the photoreceptor layer. The non-conforming type has an inverse RPE detachment, which causes a compression of the choriocapillary layer, which causes injury to the RPE-Brooks complex and can predispose to CSCR and CNV. Next, a word about peripapillary pachychoroid syndrome. The choroidal thickening associated with the intraretinal or subretinal fluid, which is extending from the temporal disc margin to the nasal macula. It is often associated with hyperopia, short axial length, and choroidal folds. The pathogenesis of PPS is that there is peripapillary choroidal congestion, which will lead to RPE dysfunction and SRF accumulation. The other proposed mechanism is that there's lack of RPE around the optic nerve head, which leads to direct transmission of the choroidal hydrostatic pressure into the inner retinal layers, which leads to the SRF and the IRF collection. These are the images of the same. In summary, I would like to say that the non-neovascular pachychoroid spectrum as discussed includes PPE, CSC, FC, and peripapillary pachychoroid syndrome. Subtle clinical and imaging findings require a high index of suspicion and careful multimodal imaging. And early recognition and follow-up and timely intervention reduces the risk to progression to the vision-threatening neovascular complications. Thank you.
Yeah. Thank you, Rupal. We have Muna madam in this room, and ma'am, I have a question for you. Would you be looking at a pachychoroid pigment epitheliopathy in a different way? Would you be treating those cases of pigment epitheliopathy very early in the disease so that you don't want a neovascular complication developing out of them? Or you want to just keep observing them? And are there any imaging markers which actually will tell which cases will go from a non-neovascular stage to a neovascular stage in this?
Yeah, at least I don't tend to over talk to the patient about this, because we know that as it is, some of them are a little anxious. I make a note of it in my file. I make sure I look at all the images. I give them an Amsler and I say, come and see me, because you may develop AMD-like features earlier. But I tend not to, over-explain things to them, because then they move from doctor to doctor, they wonder what to do and all that. So this is something I just make a note in the file and say that we need to look out. But I really don't know whether we are looking at any biomarkers as far as progression is concerned. I don't know about Jay.
Jay, your
But
thoughts?
just I just make a note in the file and I tell them watch out for early AMD. That itself makes them worried, so I don't tell them too much.
I like this approach. The only thing I specifically look for, if you are, I think the audience, the most important thing is to identify PPE, because many a times we don't try to even understand whether there is a pigment epitheliopathy or not. And I'm sure all of us have seen that these patients are always thrown into macular degeneration and told that it is AMD. At least in the West, it is very common to put everybody in the AMD thing. Uh, the one important thing which I really like to see in these cases, carefully on the OCD, if there is any DLS. If I'm seeing any DLS associated with PPE, which we diagnose on autofluorescence, then I think then stepping up and getting an OCT angio, making sure there is no new vessels. It is possible that you can have a DLS without new vessels. So just to a little bit more thought into this, and what Madam said is the right thing, that don't talk too much, follow them up just closely. That's all.
Can we have one more mic, please? One
No,
more mic.
I'll okay. No, I actually, when you said biomarkers, any patient with CSR nowadays, even if they're around 40, if I see even one yellow spot anywhere in the posterior pole, specifically away from the fovea, I'll get an octa straight away. So for me, it's not anything extra that I'm doing for the patient. I may not do an FFA ICG, but that is part of my evaluation for any CSCR patient.